Welcome to the 129th episode of the Hope Illuminated podcast, where we share powerful stories, science, and well-being strategies. Here, isolation and despair can be defeated and a passion for living rekindled. No flash required for our journey, just fired up listeners ready to gain guidance, myself and our expert guests. We're going to be talking about something today that's very complicated and very important, and that is the complex relationship between pain, opiates, addiction, and suicide. And I have with me an expert and a researcher from the University of Alabama, Birmingham, Stefan Kertesz. And we're going to be talking about some of his research and his calls to action in people that are experiencing these complicated relationships between these things, as well as the people who are in a position to make change. And as some of you know, this has touched my life personally. I do have a loved one in my life that has been in and out of this life-threatening addiction, and there have been long periods of sobriety and well-being, and then there have been long periods of despair. And really difficult times. So I'm really grateful to all of the people out there that are working hard to help us find our way through and to support people who are going through these very difficult times, find hope, and again, a rekindled passion for living. Stefan, welcome to the show.
Hi, I'm glad to be here.
Awesome. Yes, I was so grateful when our paths crossed, and I was like, oh, this is very interesting to me. I really want to unpack this and share this with our listeners about your particular interest in these issues that impact so many families. Can you tell us a little bit about what you do every day?
I am a mixed faculty member, doctor, researcher. So each day I usually have a degree of all those things. Usually there's some research meetings. There's meeting with medical students or residents at the University of Alabama at Birmingham. And I'm either talking to my own clinic about our patients, or I'm going in to see my patients, or going to the hospital.
That makes for a nice and varied day. A little of this, little of that keeps you on your toes. But I'm also guessing that each of your areas of work informs the other. Is that right?
Absolutely.
Yeah, I think it's really helpful for practitioners to get a sense of, how understanding does this work or not, and for people doing research to have some boots in the ground perspective about what they're actually asking.
Yeah.
Yeah, great.
Go ahead. Sorry.
No, I was just going to say, and within that, all of those areas, what's your niche area? What are some of the burning questions or the areas of expertise you have in your practice?
So historically, I've really focused on the care of vulnerable populations who often get the short end of the stick in our conventional healthcare system. So I started out of residency maybe 27 years ago at Boston Healthcare for the Homeless program, and took care of homeless individuals at a very good program where there was a lot of mission focus on getting the right care for folks who had a lot of health system distrust, a lot of pain, and a lot of medical vulnerability. And I moved later to Alabama. I've wound up working in the Veterans Administration. And the core question that keeps me going is, how do we make sure that mainstream healthcare systems, which often fail to consider people's individual needs, do a better job?
Yeah, I'm grateful that you talked about, first of all, for your service both to the veterans and people experiencing homelessness, and I think one of the things that I learned that really came to life in our journey in supporting this person that we're loving and caring about is that that pain in and of itself is connected to suicide. And the misery of being in long-standing, intractable pain. I mean, that is the definition of despair. Definition of despair. And then you layer onto that, the complexities and the pain that's associated with addiction and substance use disorders. It's just a spiral and a cycling. What's the backstory? Like, what piqued your interest? Do you have a personal impact related to this that keeps your passion going when stuff gets hard? What's been your journey in this work?
Well, I think all along when I took my first job, I was actually before there was aggressive promotion of opioids. And I was at times prescribing them, but I always found it to be a challenging decision when somebody had potentially a history of addiction, severe pain. And nonetheless, I treated them with prescription opioids, but sometimes didn't think they were the right thing to give, and sometimes continued to give them. As public policy attention focused on the rise in misuse among young adults, I kept wondering what this meant for our prescribing, whether we were going to get caught in some sort of vice where we'd have to stop patients who are potentially benefiting or dependent and maybe not necessarily benefiting, but wouldn't do well if we just took them off. And somehow that's exactly what happened as we first reacted to this incredibly devastating opioid crisis, some of which was really caused by excess prescribing. I began to see that the pressure was on to try to take everybody who was on these medicines off of them. And one day, I didn't like what I was seeing because it seemed very reactive. It seemed like it wasn't a process of listening carefully to individual patients. One day, I even found myself standing in a pool of blood from somebody who had shot themselves in the arm, not to die, but as a kind of suicidal action. And I realized, this was after their prescription opioids had been stopped, but I didn't know the full backstory. And I began to hear about actual deaths by suicide as patients were coming off. And I didn't trust that I understood what was going on. I knew that some people would say, oh, just don't stop them too quickly, or we should never stop them. But I kind of think that it's not helpful to try to understand complex events through the bottom of a pill bottle. There's more going on. And I just came to think, let's try to understand what this is, while at the same time, in the background, I've been advocating for policies that would at least be protective of patients.
Yeah, my loved one who has gone through the withdrawal a number of times at this point says, it feels like you're dying for a week. It is so uncomfortable. It is so torturous. I can't do it again. I just can't. And in this particular system that he's in, there's just not a lot of options for him. And so again, just that feeling of being trapped, I guess, is what it seems to come down to me over again and over again. Like, I'm damned if I do, I'm damned if I don't. If I keep continuing, then I have these consequences. And if I don't, then I have these consequences. And, I'm just appreciating more and more that sense that my back is up against the wall. I have no choices in this situation that are going to benefit me, is the place where people find that I just can't do this anymore kind of sense. Just the needing the relief from that sense of the overwhelming pain that they're in.
Yeah.
Yeah. So talk a little bit more about what rings your bells today? What is the stuff that that gets you really excited in your work here? Because this is daunting stuff that you're working in, but from the organizational policy perspective, to the individuals that are suffering so much.
I think there's a couple things. First of all, I'd like to ask if we have assumed too much about whatever the problem is in front of us. Sometimes asking those questions is not smart. Like, if you ask me where are the noodles, I'll be like, well, they might or they might not be in the cupboard. That's not a great place to impose my questioning attitude. On the other hand, when something devastating and complicated is happening, I want to figure out what's really going on. I also really want to move where my moral and ethical sensibilities lie. So, to my view, people who have complex combinations of pain and disability and a history of trauma from our healthcare system, they deserve some effort to really understand what we are doing to them in the name of resolving the opioid crisis. And that could be through storytelling. It could be through writing opinion pieces or advocacy. I've done some of those things. But there is a special role for research that seeks the deep story, not just surveys, not just large databases, but really seeks to understand what happened to people. And I have a team that has all the requisite skills to understand people's stories in depth, collection of narrative, understanding what to ask about to learn about suicide, opioid expertise, people with lived experience who've lost someone to suicide. And so we're in a position to ask the hard question. And I would say we're in a position to ask the question that most people are avoiding.
You're singing my story. I mean, that's it. I mean, I think when we can balance some of the, more quantifiable, objective data, which tells us pieces of the story, but certainly doesn't tell us the whole story. And we run the risk of misinterpreting that data when we don't know what's behind it, with the more in-depth, qualitative, nuanced patterns that we can say, okay, this informs us on this particular part of the answer, and this informs us of, and it just puts that context, the texture around what it is like to live with this. What is it like to live through this? What is it like to be impacted by these kinds of things? And to bridge those things together, I think, is where our really deeper, nuanced understandings come from, but also our better solutions. Is that kind of your approach, is to blend the two?
Yeah, I mean, I believe that sometimes health systems do the wrong thing if they only rely on statistics. But if you can get people's stories, including the stories of patients, especially, who often see uniquely where we fall short, that can enable the people who work in those health systems, especially their leaders, to see a new angle. Obviously, I'm trusting to some degree that there's goodwill in our healthcare system. There's goodwill even among managers and insurance companies. Boy, I hope that's true. And certainly among federal officials who I've met and talked to, many of whom really care deeply that they don't cause harm. But we need stories directly from individual families or patients or survivors. And some of that came to me long before I touched the opioid issue. When I was working, and I'm still doing research on homeless healthcare, it was one of my patients who became a national advocate, telling her story all the way up to, I don't know, like the Secretary of Health and Human Services, demanding systems change because of her own experience. And people did not ignore that.
Mm-hmm. Yeah, it's our stories that move our hearts. It's our stories that get us to take action with our feet. Data, theories, they only get us so far. But when we see another human being in front of us, somebody that we're like, that could be my sister, it could be my neighbor, I get this person as a fellow person on this planet, then it's a different impact. Then we can come together, actually, sometimes even across divides, when we really understand that storytelling piece of it.
Yeah.
So take us another step into what you've been learning through your research, and what's emerging, and what your current research project is all about.
Yeah. So over the question that emerged for me, partly from watching individual patients, and was that I could see that some people who had been on long-term prescribed opioids were destabilized as they were reduced. And I'm not saying all those people had addiction. I'm not saying all those people had pain. I'm just saying there was a change we were making in the healthcare system that was leaving, some patients better, but a meaningful percentage worse. And statistical data began to emerge saying, on statistical average, looking backwards in databases, when patients go off of these medicines, there are often, not always, but as many poor outcomes as good ones. A meaningful number, by the way, say, I don't feel different. So I'm not trying to make this any less complicated than it is, but a meaningful number feel worse. And there's even some statistical data that showed from our Veterans Administration system, I was a co-author, that showed a higher rate of suicide death and overdose death among people taken off of opioids, which it's not an argument to keep every human being on them. That's not what I'm saying.
I just want you to say that one more time, because I think it's counterintuitive to the general public. When people were taken off opiates.
When people were taken off of opiates in our VA system, statistically, there was actually a higher rate of death by suicide and by overdose than among those who stayed on. Now, our database was not a trial. Our database was just looking backwards into only the things like whether the prescription continued or stopped. And we tried to deal with differences amongst people, but we never really knew, why did they go off in the first place? Were the opioids stopped at people's request? Were they stopped because doctors felt pressured to stop them? Were they stopped because the patients are doing terribly on them? So it was just a signal, not an answer. And I began to see more studies, many of which showed a hint of trouble, a hint of greater risk for patients coming off these medicines, but not always. And I began to think that these large database exercises just couldn't show us what had happened in the most tragic instances where people had taken their own lives. That, to say, just don't stop them too quickly, assumes we know why somebody took their life, that it's just acute withdrawal. I felt that was pat, that was simplistic. why assume we know when we haven't asked?
Mhm.
So we decided that we should investigate individual cases and learn about individual actual suicides from people who lost somebody, a family member or a close friend, and to interview those people in depth and where possible to collect the medical record. And that's the study we're beginning now. So as we talk, we'll talk about what we're learning while doing it rather than what the final results will be. But our goal is to get 120 case histories. Our goal is to do that with a mixture of people who were veterans and people who were not veterans. The Veterans Administration is actually funding the study. And the hardest thing of all is to find the families and the friends who would wish to talk to us. That's really a major undertaking because there's no master list. And even if there was a list of everybody who suffered a loss, it would be a little creepy if researchers went up to them and said, hey, knock, knock, I heard you suffered a devastating tragedy. Would you like to talk to us? Like, that's not going to work.
Mm-hmm.
So essentially what we've done is taken the view that we should put our message out to the public, speak in places like this, and see who wants to talk to us.
Excellent. Yes. And so we have a partnership, an emerging partnership right now with United Suicide Survivors, and we're hoping to help you with that as well to get this message of, if you know someone or if this is true for you. Please come over and give us your input and your insights. I also just wanted to check in on the lost survivor angle. So the friends and family that have lost someone under these circumstances. I would imagine it's even harder, but possibly more direct to see about the people who have survived suicide or who have survived a near miss. Have lived through it basically, because I always say that that's the black box, that any loved one is just going to be biased by their own perceptions of what happened. They don't really actually know. But it's a proximal measure. But I'm just wondering about that as well. If there's a group of folks that maybe we can reach that could inform us from that perspective.
Well, first of all, it seems like the obvious thing that should be done. People who are currently trying to survive with long-term pain and who may be at risk of suicide are people who researchers should talk to. There's a couple reasons we haven't done that as a formal research study, even though I take care of people who are sometimes in distress of that nature. Probably the biggest reason is that the ethics of how to establish first contact as a researcher for somebody who's in crisis are very complicated. In essence, if I'm not going to take care of you, and I reach out and I find somebody in Vermont who is in absolute crisis because their doctor's just been taken in by the DEA and they are close to killing themselves, it seems to me so challenging for us to then say, hey, let's have a research conversation about your distress.
Of course. I'm talking maybe more about people in long-term recovery who maybe 10, 15 years, who 10, 15 years ago had this kind of intense experience.
And then they survived and they did well.
Right.
That's actually a great question. And I would love to do that.
Yeah.
In some ways, I think we could get there. And it's just a matter of putting one foot in front of the other, and launching each study takes a certain amount of time and energy. And if it works, people will consider funding the next one. But actually,
you're right. The ethics and the safeguards would need to be heightened for sure. But I do watch what's happening in some other countries like Australia and New Zealand, where they really require in a lot of places the people who've actually lived through the research question to be part of the research design. And
yes. Well, we have. I can could I talk about a few people involved with us?
Of course.
So that's a really important part of our study. Our inspiration for doing the work wasn't just what I saw, but it's actually a woman who lives here in Birmingham, Alabama, named Anne Fuqua. And Anne herself has long-term severe pain. I'm not sharing a private confidential information. She's been written about in the New York Times, and she has been on long-term opioids and even at high dose. And she was the person who first told me that she was seeing mention of suicide online in Facebook communities, on what was then called Twitter. She kept her own records, her private records, in essence, of every mention she could find and cataloged them. And she tried to check when people reported that there was a suicide, was they all talking about the same one, or were they speaking about different ones? And it was really her effort to track them that led me to think we could actually study them. And in fact, almost all of our plans for how to present ourselves to the public were inspired by her, and we still consult her. She's an employee of the study now, guiding us in how to think about outreach. The one thing we can't do for ethics reasons is simply take somebody's public media that she's saved and say we're studying that. It's not a rigorous data collection, and there's no informed consent. So she has a record system which has helped us understand that there's this problem out there, and she's helped guide us. But the other people who kind of played a role here, the brother of a patient who died a year ago by suicide, the patient who died was not my patient, but somebody who was getting care in California. Danny Elliott, also covered in Vice.com news at the time. And his brother, Jim Elliott, joined our team to advise us also on how to get the word out about the study. Danny Elliott had a complex electrical injury that resulted in long-term pain. And I had spoken to him when he lost a doctor in 2018 or 17. And I was just trying to figure out where he could get care, because I was in the VA. He wasn't in Alabama. He was in another southern state. And I remember thinking, if he doesn't find a doctor, he might die by suicide. That was my fear. And he eventually wound up with this doctor in California. And that doctor was investigated. And the initiation of an investigation like this often involves closing down the practice. And so Danny died shortly thereafter. It was covered in a very upsetting podcast by Vice.com. And those are stories that, Jim's on the study advisory team. Similarly, the only person I know to have sued and won in court is an advisor to the study. She lost her, I think, ex-husband in a similar situation, and her case was covered by STAT. So we look to people who've lost people and people with pain and people with disability to revise our questionnaires, to revise our interviews, to help us present ourselves to the public in the right way.
Thank you for that. Those stories are really powerful, and again, speak to the importance of this work. What are some of your hypotheses now that you've kind of started to develop your approach? What are some of the things that you're trying to test?
So this is descriptive work. And when you look at individual deaths by suicide, it's sometimes called a psychological autopsy. And we were trained in that. And we start with the supposition that a suicide is a complex event and that there's likely to be multiple interlocking factors that play a role. Some of the things that we're especially curious about are whether the actual encounters with the healthcare system were themselves traumatizing. So I'm looking and listening for stories of impasse, moments of conflict between doctors or other prescribers and the patients. I'm also looking for stories of disability and potentially substance dependence, either addiction or not addiction, in the past of the person who died. I'm very curious about two key concepts from the suicide literature. One is called perceived burdensomeness, and it's a mouthful, but that refers to the idea that you are now a burden to others and that they would be less burdened if you were not there. And I want to hear or learn whether that happened for people. Another one is called, it got another mouthful for a name, thwarted belongingness, but the notion that you no longer can participate in and be in groups that you normally were part of. And these are two concepts that really were developed by a suicide scholar who's part of our team as well. And his name is Thomas Joyner. And I tend to think that the stories of these individual deaths will sometimes have disability, they'll sometimes have real impasses in healthcare, and that some of these concepts about how we relate to other people are going to be really important to understanding what happened at the end. In terms of helping healthcare systems, I really want to know if there was healthcare contact and if the ball was dropped. That's important.
Yeah, absolutely. And I just feel for all the parties involved, right? The physicians that we're trained to say, pain is like vitals. We've got to be able to treat the pain. Here's your tool to treat it, give it widely to help people with their suffering. And then realizing, the downplaying of the addictive qualities in the early days was a real trap for those physicians. And then, watching the overdose skyrocket, and then the policymakers going, oh no, we have to do something drastic and now, and coming up with this incredibly restrictive policy as a way to prevent the overdoses. I mean, we can understand where they came from for that, really crisis moment in healthcare. And then the people with boots on the ground who are afraid if they don't follow these policies, they might be sued. I mean, it is just a tangled web of a lot of suffering, a lot of fear, a lot of reaction.
Reaction.
And across the board.
That reaction, and that's what I'm so much want to push back against. I think that the instinct to prescribe so much from 1995 to whatever, 2015 or whatever, off maybe 2012 was our peak, was sort of, this is a simple problem, you'll fix it with a prescription. And then there were some downstream effects that were not that good. And people began to say, well, the opioid crisis, I remember reading a politician who said, we can fix this with a click of our fingers just by getting those doctors to stop writing those prescriptions. And of course, doctors did stop. We've reduced down a lot. It turned out that it wasn't something that we could fix with a click of our fingers. We always want that simple solution, and we don't get to have it. That's what I would say.
Yeah, and that drove a lot of people to the streets, which entered a whole nother level of danger and complexity, and then fentanyl access. I mean, it's a very, very challenging problem to solve. So I'm really glad that you and a bunch of other smart people are at the helm trying to at least understand all the ways that these things are intersecting. And of course, I'm a huge fan of Thomas Joyner as well. Talk a lot about his model because I think it's something a lot of people can relate to. This idea that I feel like maybe my death has more value than my life, or the feeling that I used to have these relationships. I used to have this sense of community, and now I can't anymore. I don't. They've left me, or I can't participate for all these different reasons. And those are profound existential aches for people when they find themselves in those spaces, and all of the ways that this kind of is a perfect storm of that.
And that's why I really don't think it's helpful to think of suicide as caused just by something we did with the prescription pad. It's part of the story, but those deeper existential questions are crucial. And any time when someone in your family gets sick, or when you get sick, particularly if it's serious, you don't know what's going to happen, there are existential questions. What's going on here in all of my life? Those things just resonate through you. And I think that that's what we want to get at.
Yeah. And you mentioned something too, I just wanted to draw out a bit, because I don't know that we talk enough about this, but the interaction with the health system and the trauma related to that. Can you just talk a little bit more about that?
Yeah. So I'm afraid, I'm sorry to say that many of us who are trained in medicine, and many of us who go on to become managers in healthcare, may have good intentions, but we're not necessarily trained to understand that people's lives are complicated, or to help arrive at the best choice by listening and learning from the person in front of us. We have an entire podcast. I guess I shouldn't plug it, but I will. It's called On Becoming a Healer. But a major theme of that is that the moment that a clinician, particularly a doctor, is reacting to somebody emotionally because they said something like, I want oxycodone, the moment you're reacting, you're not asking questions. And the questions are more important than your reaction. You need, and this is something we have a problem in medicine. We have a problem training ourselves to hear people as individuals. We have a problem treating a patient as an adult with equal value and fundamental respect. And our healthcare system is in many ways designed to bureaucratize interactions so that those of us who come through medical school kind of become what my friend of mine calls efficient task completers. You give me information, I type it into the medical record, I write a prescription. And that gets in the way. And I'm not speaking about bedside manner. The issue is whether you genuinely try to understand what another person is dealing with. And the most extreme example that I learned from a colleague of mine is if you came across a close coworker crying in the parking lot, and it's just you there and them, you would say, what is going on? I see you here. I don't know you super well, but can you tell me what's happening? Because I want to help. It's the normal response.
That's
But
right.
if you go to the doctor's office and you say, I'm really troubled about what happened at our last visit, the next thing the doctor is likely to say is, I'm so sorry. Do you have any allergies? And,
Hmm.
like that could be nice, but that's not inquiry. And our whole entire healthcare system is sort of set up to stand in the way and to train us to not value those same questions that you as an adult would ask of other adults when you care about them.
And that's true for frontline healthcare workers. It's also true for the mental health. I call it clipboard counseling that feels more like interrogation
Yeah.
than any actual help or
Yeah.
support in the situation, and really lets people feel like they're objectified in some ways. They're just kind of flying through a system and boxes are being checked and then things are being doled out rather than really understanding human to human what's actually happening. And again, shout out to the people in healthcare system. They are burnt out. They are
I know
constantly
that,
being
of course.
squeezed, right? Squeezed to do more with less, more with less. I mean, COVID just about crushed everybody who is in healthcare, and they're still showing up trying to do their job. I mean, it's very challenging, and with insurance and all these regulations, and I'm also hearing about a lot of uptick of violence in all kinds of healthcare systems. So they're afraid for their safety in many ways. It's
I understand that.
it's rough. Yeah. Yeah.
And I didn't want to minimize the burnout factor on
Mm.
healthcare clinicians. The bureaucracies that we work within are damaging, and they are part of the problem too. Um, at the same time, I do want to underscore that those of us who work in healthcare, asking additional questions usually doesn't take more time. People think it does, but sometimes getting the right answer early involves listening, and that saves you several steps.
That's right.
And it's way more rewarding.
Hmm.
Um, Maybe that's a slight step away from the subject of our study, but it is the core reason that we're interested in this, is to get people's real stories.
Well, and to change whatever the root problems are, the root causes. And if
Yes.
one of the root causes is a traumatic experience with the healthcare system, then we need to know what might be driving some of that. And this is part of that. It's a systemic issue of how we set things up right now in our healthcare system. So now we'll move to the so what. You're in the midst of this research, and so what are you hoping will change once we have some of these answers and some of these insights?
Well, in one way, the mere fact that we are making the inquiry and that we've begun the work, that we're doing interviews, we've done 11 or 12 in-depth interviews so far, and we have lots of people lined up who appear to want to talk to us. The mere fact that this inquiry is happening and that it's federally funded means that we can say these deaths are not ignorable. And
Mm-hmm.
if we care about them enough to look at them, we should be already working on trying to prevent those deaths. So I think there's a what now message that can be sent, which is, a federal agency has said we need to stop these deaths. We need to at least understand them better. In terms of, there are sort of responses I have for people dealing with pain and opioid issues as individuals. And then I have other responses at the policy level. But at the individual level, a lot of patients are right now being stuck in a situation where a doctor or prescriber says, I don't serve anybody who's on opioids. That's been
Mm-hmm.
documented. Or they say, I have to take everybody off. I'm sure it'll make you safer. And if someone's in that difficult situation, and I can send you the link, we have a guide that I wrote just for families trying to cope with that situation. It doesn't guarantee a resolution that will work, but it walks people through how to have the conversation with that clinical provider and what to do if they are completely unable to talk to you.
Mm.
Starting with just asking questions and taking notes with a family member present, all the way down to maybe considering switching to buprenorphine for some people, or even in the extreme example, going to a methadone clinic, which are increasingly used to receiving pain patients. So we do have a guide that people might want to look at. And I think that people who are in a troubling situation like this should also consider advocacy if they can. And that's hard to do when you're in a disability situation. But the health plan leaders, the Medicaid directors for many states still think that if they can just show that they're getting everybody off of prescribed opioids, that they're saving lives. And yet the group that really disagrees with them on that are the Centers for Disease Control and Prevention and their guideline, which says be really careful with this.
Mm-hmm.
So right now we have policymakers and legislators and politicians and even health plans that have decided that they can be casual about what they do with people who have long-term dependence on prescribed opioids. And we have major guidelines like the CDC saying, don't be casual about this. And the only way to close that gap while we wait for research is for people to speak up and to say, I'm concerned that right now our state's Medicaid plan is not taking into account the needs of people who have long-term and severe pain. And the CDC says you should, or they can speak to health insurance companies. I admit that it would be better if our study was already done and we could understand more. And I don't think prescription policies are going to solve all of this. I really want to underscore that there's a lot more that is needed to provide really good care for people with disability, pain, and mental risk. And those kinds of advocacy need to be put on the table too. I could mention briefly, there's a lot of money coming to states because of opioid litigation, like millions and millions of dollars, maybe billions. It would be reasonable to speak to your legislators in your state and say, look, if there's going to be opioid settlement money, some of it needs to be dedicated to protecting people who have severe disabling pain. That is a serious issue. And it's part of how we got into this mess is that we took some shortcuts. So let's try to do better. Those are things I think people could do.
I think that's great. And I really appreciate that you have written a guide that will help families with this advocacy role with their individual practitioners, because I know for so many people, myself included, your doctor tells you the thing and that's it. They have such a position of authority that you don't necessarily know that you can, advocate for yourself and maybe guide the discussion as a conversation rather than a foregone conclusion. And then I also appreciate, that you're, leveraging some of this intelligence around the stories you're gathering and so forth to say, like, let's really think about what's happening here on a policy level, because once those policies come through, millions of lives are impacted really quickly. And so to get, kind of the full circle of here's the data from the CDC, here's what we're learning, here's what we're learning from boots on the ground. Let's have all of this informed, really thoughtful policy rather than just reactive.
Yeah, I agree completely.
I'm going to do a quick recap, and then I'm going to come back to you for some final thoughts about what you want to make sure that our audience leaves with. So again, here I'm speaking with Dr. Stefan Kertesz. Sorry, let me try that again. I had it and I lost it. So I'm just going to do a quick recap here, and I'm speaking with Stefan Kertesz about the impact and the intersection of pain and opiates and suicide. And we've been talking about the very complicated interactions of this and the fact that we as a country have had a pretty reactive response to the increasing overdose rates. And those responses have probably, given our CDC data, increased a lot of harm to people who are in intractable pain and having their opiates taken away without a real great plan on what they're going to do to cope. And so we are now looking at the many types of root causes for this, the many types of ways that families and individuals are impacted, and thinking about this through a lens of a suicide risk model that many of us are familiar with around feeling like a burden or feeling isolated and alone when you are suffering and feeling trapped. And how all of that is a perfect storm of risk in these situations. So again, I'm really grateful for this work and your leadership in helping us expand the conversation, understand in a deep way people's pain, both physical and emotional in these circumstances, and to find new and better solutions on how to help people. Stefan, what do you want to make sure people walk away with? What are some of your final thoughts?
I think I have three. One is, if you have suffered the loss of a close friend or a loved one and would like to consider being interviewed to share that story with our research team, we have a website and it's easy to do. It's go.uab, that's my university, .edu/CSI, go.uab.edu/CSI.
And we'll definitely have that link in the show notes if you didn't catch that because you're driving. So come back
Sure.
and visit the show notes. We'll make sure you have all the links to the studies and the also the papers that you were talking about. Will all be there if you want to dig a little deeper. So definitely come on over.
Another thought I have here is just to remember that the story of what's sometimes, let me put it this way, the story of what we call the opioid crisis in many ways involves leaping to conclusions that problems can be solved quickly without thinking too deeply. Mm-hmm. The situation of people with pain, with disability, with dependence, and with addiction is not one of those problems. And the best thing we can do is to really pay close attention to the details of their life and then ask of our healthcare system that they listen and are responsive. And I know that's going to take some work, but I think that's probably one of the most important things we can do. And then finally, for those who are inclined toward advocacy, it's very appropriate to go and share your concerns about care of addiction, care of disability, care of pain with your state legislators, with your governor, with your senators, with your representatives. Even if there's not every single study reported yet, you have a right to speak and to share your observations now.
And you might be the most important voice in the room. No, yes. You don't need a long pedigree of degrees after your name to make a really big difference, human to human. So thank you so much for that conclusion and that call to action for all of us. There's probably not a family out there that hasn't been touched in some way with some of these issues, whether it be pain, addiction, opiate, or overdose. And you really have a very humane approach to this, and I really appreciate that. So thank you for your work. I'm really glad that our paths have crossed. I think this is probably just the beginning of a lot of things that we'll probably do together moving forward, and I'm grateful for that. Thank you to all the listeners who have spent some time with us, and also for all of you that have that lived experience that brought you into this conversation. I'm grateful for the wisdom that you're bringing to help us figure out some solutions and a different way of doing things. Thank you to Dave for making us sound awesome, and for all of the people doing this work in this very challenging area. There is hope, and together, when we pull together, we will find some answers. So closing here, we have open your heart, challenge your thinking, and take action to save lives. Together, we can restore dignity and sustain a passion for living.